For those who don't know me, I'm Luke Parcher. I'm with Real Progressives and Real Progress in Action. I'm a volunteer and I'm on our leadership team. I'm a student, activist, and political commentator, and I am just absolutely thrilled to be a part of this summit. Thank you all so much for tuning in. I do want to quickly shout out all of our sponsors: March for Medicare for All, Physicians for a National Health Program, Real Progressives, Yellow Vest Actions, and Indie Left Media. Thank you so much to everybody who put this all together. And without further ado, I would like to introduce our fantastic panelists here today. So we have Dr. Anna Malinow. Dr. Anna Malinow is a retired professor of pediatrics from the University of California, San Francisco. She's the past president of Physicians for a National Health Program and a lead organizer for the National Single Payer Steering Committee. Anna, thank you so much for taking the time to be here today. We also have Dr. Ted Brown, who is Professor Emeritus of History and Public Health Sciences at the University of Rochester, where he taught for 42 years. He served for 25 years as history editor of the American Journal of Public Health and has co-authored books on the history of health reform in the United States, the American Left, and the World Health Organization. Ted, thank you so much for taking the time. And we also have Dr. Steffie Woolhandler, who is a distinguished professor at the City University of New York. New York's Hunter College, a primary care doctor in the South Bronx, and a lecturer of medicine at Harvard Medical School, where she was formerly professor of medicine. Steffi, thank you as well for taking the time. So just so that the audience understands how we're going to format this, each of our guests today has a presentation to go through. We're going to start with Ted's presentation on the history of health policy in this country, and then we're going to get Anna's presentation going into some of how the system currently operates, and she's going to show you how the healthcare system is divided up. And then we're going to finish with Steffie's presentation on the privatization and the harmful effects of it. I'm sorry to see that we may have lost Anna there. We'll try to get her back as quickly as possible. Just quickly for the audience, we are going to do a Q&A at the end of this panel. So if you'd like to participate in the Q&A, please put your questions in the chat box, and we will have people watching for questions to ask our panelists after they present today. And without further ado, I will pass things over here to Ted to begin his presentation.
Okay, let's get the slides up if we can. There we are. I'm going to try to really tackle this topic. It's a very large one from a very thematic perspective. Instead of trying to give you all the nitty-gritty, I'm going to give you a broad overview, which is that if we look over a century or more of health policy struggles in the United States, we can see it as a battle against red baiting and the labeling of any progressive program, especially at the national level, as socialistic or communistic. And I'm going to not only focus on that theme, I'm going to use a lot of illustrations that are going to include some photographs and a lot of cartoons, but I think they will effectively make the point. So let's get started. And a good way of framing it is to begin with the first slide. There we are. I hope you can see it. It's a very broad perspective on the end of the world as we know it. Moments of panic on the part of the American elite and the American established interests, who at various times in the 1790s were facing the threat of public schools and then public water systems in 1808, etc., right on through when this cartoon was first published in 2009 at the launch of the campaign for Obamacare, with the attempt to get a national health program yet again. And the constant refrain was, oh my God, the world is going to end as we know it. But this is really an optimistic perspective. Not only does it underlie the tactic that's used, but it also expresses some optimism, because all those fears in the past about public water systems and public highways and public schools were overcome, and those were established as major American institutions. The notion is in 2009, we're facing those fears again, we're facing that labeling, but maybe we can finally optimistically move forward. As we can see, it didn't turn out quite that way. This cartoon leaves out a couple of other major red baiting episodes in the history of American policy. We look at the next slide. Back in 1965, when Medicare was going to be put into effect after a long uphill political battle, it was, of course, labeled as socialism on a socialist plot. And the cartoon conveys a notion that nothing new. 30 years before, so was Social Security. So seeing those obstacles were overcome, but this refrain is an important theme to focus on. If we look at the next slide, we can put things in an ironic historical perspective. Because in fact, the very notions of social insurance, of health insurance built on social insurance models, goes back to the late 19th century and to the policies of Otto von Bismarck when he was chancellor in Germany. And ironically, he intended these state measures as alternatives to socialism, as a way, as he puts it, if you can read the small print on the slide, to bribe the working class away from the seductions of parties on the left and the great threat of communism and socialism, and have them become loyal to the state because of the benefits that were provided for them in their old age, when they fell sick, and so on. And his strategy was quite successful in that he did avert what might have been seen as incipient revolution in the late 19th and early 20th century, but it didn't work in the sense that those very policies were adapted by socialist parties working within the democratic context and gaining increasing seats in the German Reichstag, their parliamentary organization. And so they were able over decades to move to policies that were more reflective of working class desires and needs. And instead of wooing them away from socialism, it made them loyal to an elective socialism and the policy that grew steadily to support those measures as part of national policy. Those policies and those approaches were introduced in the United States essentially by this man. He wasn't the only one. Next slide. That's Isaac Max Rubino, who was an emigre to the United States. He was originally born in Russia, but he was educated in Germany, learned in great detail about the German social welfare system and the kind of measures that Bismarck had introduced. And when he came to the United States, became a founder of the American Socialist Party in the early 1900s, and became a very important leader, holding government positions as an expert on the German and then widely European social insurance measures for covering workers' sickness, workers' old age insurance, workers' compensation when they fell ill on the job, and that sort of thing, and became a national leader with those goals in mind. The ideas were picked up, next slide please, in its significant numbers by the American labor movement, and in particular by unions that were led by women, very powerful and impassioned unions. And you can see in this cartoon from the early 1900s, a very important woman figure in the front, the maternal figure, who is the strength of a family. And she is cautioning them that they should provide protection against destitution and illness by protecting themselves with the umbrella of health insurance that they would push for to be created as a state policy. And this was a very important part of the labor movement in the early 20th century. That campaign was taken up by an organization called the American Association for Labor Legislation. Next slide, please. Which was not led so much by women leaders, but rather by male leaders. And you can even see in the change of the figure here from a powerful woman figure to male figures as the principal characters here. A message is being told in this cartoon. The American Association for Labor Legislation will push for workmen's compensation, will push for sickness insurance and other measures to protect workers against the various infirmities and dangers that they were exposed to. England was far ahead. That's the worker on the left with a very full umbrella. The American worker at that point had only workmen's compensation, not very full coverage. And the message of the American Association for Labor Legislation in this campaign was to try to emulate what had already been done in Britain as the Labour Party grew in Britain as a democratic socialist institution within the parliamentary system. If America could move in that direction, it will be a very important advance for American workers and their protections. That campaign was picked up by 1912, next slide please, by Teddy Roosevelt, who at that point was running as the Progressive Party candidate for president. He had already been US president as a Republican, broke with the Republican Party, didn't agree with their policies, and this was the convention that officially nominated him in 1912, That convention not only chose Teddy Roosevelt to be its presidential nominee, but it also adopted a platform which included sickness insurance, health insurance, as one of the major goals to be achieved by American policy. And there was a great deal of energy and enthusiasm coming out of that convention. The Progressive Party didn't win. Woodrow Wilson was the successful candidate in that election. He didn't support those policies. But the ideas of promoting a health insurance program were taken up by others, were even taken up by progressive leadership in the American Medical Association and by others in the American political environment, so that support for it grew steadily in the 19-teens. At the state level, some states got very close to passing sickness insurance, health insurance at the state level, others not so much. But then the campaign foundered with America's entry into World War I. And you can see some evidence of this indirectly in the next slide. The old red baiting tactic, the socialist labeling tactic, was here in evidence in a pamphlet that was published in about 1917, 1918, claiming that labor's attitude towards compulsory health insurance was really quite negative. Someone alleging to speak for labor, Mrs. Sarah Conboy, claims that workers didn't want compulsory insurance. The very choice of language makes it seem negative and Bolshevistic and collectivist. And it was also a time when America was just entering World War I, and our great enemy was the Germany. So anything associated with Germany, like Bismarck's insurance measures, would be considered as negative. It would be socialistic, it would be collectivistic, it would be compulsory, and it would be German. All things that were sufficiently negative and used symbolically and manipulatively in the political environment to really very rapidly reverse support that had been building up for national health insurance in that decade and squash it. With the coming of the Russian Revolution, a major Red Scare in the United States in the late 19-teens and into the 20s, these ideas just were thrown out of consideration. And only slowly by the later 1920s did they begin to come back. So by the late 1920s, it was possible again to debate the merits of national health insurance, sickness insurance, versus the continuation of the American system that was argued in the pages, for example, of The Nation magazine. If we see the next slide. Rubino had been invited to make the case for national health insurance. And then he was answered, as The Nation tried to maintain a balanced debate, by Morris Fishbein, spokesman for the American Medical Association, who, of course, used the tactic of labeling it as socialized medicine and describing it as robotic, automatic, not personal enough as we would want our medical care to be. And that's captured here in this robot figure that really is the very negative image of what would become medical care under a so-called socialist system. But there were still those in favor of it. And by the late 1920s, a large consortium was created called the Committee for the Cost of Medical Care. Please, next slide, please. Which pulled together leaders from the social sciences, from medicine, from public health, to try to examine the American healthcare system as existed in the late 1920s and early 1930s, and to make a very gentle, modest case for moving to new forms of organization to eventually consider, on a local and maybe eventually a national basis, a national system of health insurance. They issued a final report, this committee that met for many years, in 1932. And that report was very modest and cautious and careful, and yet the American Medical Association was waiting to jump on it, as it did, as you can see in the next slide. As soon as the final report was issued, an editorial was published in JAMA, the Journal of the American Medical Association, which said such things as these. You may not be able to read the fine print, but I'll read for you some of the principal language. Those who are pushing for even gentle experimentation, mildly, carefully, are nonetheless forces representing health officialdom, social theory, socialism, and communism, inciting to revolution. And repeating that language. These modest recommendations are really an incitement to revolution, and we in America must mobilize against these terribly un-American, dangerous, socialistic, Bolshevistic tendencies, that being the now very common strategy. Those threats were so great that when President Roosevelt, Franklin Roosevelt, put forth his Social Security measures in the mid-1930s, he was very careful, against advice of some of his advisors, to leave out any mention of health insurance as part of that. If we're going to get Social Security through, if we're going to create retirement benefits and other essential Social Security measures, we cannot possibly include any reference to health insurance, because the mobilized medical profession, the commercial insurance industry, will take that language again and use it to squash not only any thoughts about health insurance, but about Social Security in general. So Roosevelt backed away, and only a few years later, in the later 1930s, when he was assured that Social Security wouldn't be shot down and it would stay as an important American piece of social legislation, only then, in the late 1930s, did the idea of health insurance, national health insurance, begin to resurface. There were important spokesmen in the academic world, in the medical world, who came forward and started promoting it very vigorously. One of the most important of these was a man called Henry Sigris. Next slide, please. Who was a professor at Johns Hopkins with great credibility, who was a medical historian and a health policy advocate. He would not only promote the idea of a national health insurance program, but he would accept invitations to go to labor forums and people's forums to promote the ideas. This was an advertisement for a forum he spoke at in Philadelphia in 1939. He was presented by Time magazine as one of the great leaders and presented with great enthusiasm by Time magazine. And yet the AMA was still, and the other opponents were still ready to use all the old tactics of red baiting and anti-socialist labeling, as you can see in the next slide. By 1939, the first measure was introduced by Senator Wagner, liberal senator from New York, beginning of a series of measures that were introduced over the next decade or so. But the AMA immediately descended on Congress, and at the testimony about the bill, as these two gentlemen represented the measures, which were very modest, as revolutionary, Bolshevistic, and the like, and that language was used, of course, with great political effect to stymie progress towards that legislation. World War II then happened, and moving forward very quickly. All those discussions were put on hold. In the post-war period, though, by this time, Harry Truman has succeeded Roosevelt, who died in office, as president, and Truman had become an advocate for the Wagner-Murray-Dingell bills, as they were called, trying to create a national health program. As soon as that legislation was introduced, as soon as President Truman began to advocate for it, the forces against it lined up, as we can see in this cartoon from the late 40s. The notion of health insurance is immediately labeled as socialized medicine, and that's meant to be some pill that an academic figure, note the mortarboard, will try to shove down the throat of John Q. Public, the taxpayer, and have him choke on it, because that's what people do with socialism and such measures. Then, a little bit later in the 40s, as Great Britain, next slide please, was moving to its National Health Service, a creation of the post-World War II period in Great Britain, that was taken by the opponents of any such measures in the United States, or much more modest versions of that, as dangerous signs, warnings, and so we should worry about treading on the thin ice of socialized medicine, beware of the British example, and don't allow the United States to move in anything like that direction. With the Cold War in the late 40s and early 50s, in the McCarthy era, those tactics became even more vigorous, as we can see in the next slide. And there's a figure of Uncle Sam naively dozing and not noticing that Russia's great aim is to destroy America, using the mechanism of socialized medicine as one of the dangerous weapons that would undercut the entire American system. If you look closely at the hand holding the shears read socialized medicine will cut off Uncle Samson's locks and have him lose his power. And the hammer and sickle is on the sleeve. It's a Bolshevik plot against the United States. There is no rational discussion in the hysterical atmosphere of the late 40s and early 50s. The next president of the United States following Truman is Dwight Eisenhower, who is, as you can see in this quotation, flatly opposed to the socialization of medicine. He's bought into that. He believes that any movement to a national health program is socialism and Bolshevism, and he will have none of it. What he does support are certain tax measures that will benefit the distribution of insurance via commercial means, an employment-based system in individual industries and workforces in which the insurance is provided primarily for profit by commercial insurers. And all that is meant to be a bastion against socialization and the inappropriate government intrusion. And that works fine for a while, but it creates what we can see as a dialectical process, because in the very process of insuring more and more workers through employment-provided insurance spreads, inflation increases, and those individuals who are least able to pay for care and are becoming most sick, that is the elderly retired, are those in particularly difficult straits because they now face having to buy care after their period of employment and coverage during work with union support, as well as management provision. And now they are facing a very rapidly inflating healthcare system, and this means that they are in deep trouble. But that deep trouble inspires a political response. And the political response is to create something that we begin to call Medicare. The first legislative measures that will provide a Medicare system that is a universal national system for a particular age group, those in the retirement age, 65 and older, begin to be put forward in the late 1950s. And as we can see in the next slide, Congress at first ignores them. The elderly, why do they matter? Until Congress discovers that the elderly are a very well-organized political group with a lot of labor support, and Congress begins to worry that they've got to do something. We will fast forward into the early 60s. John Kennedy runs on a pro-Medicare platform. He wins. His administration in the early 60s begins to promote Medicare. There are bitter battles about it, with the familiar suspects lined up against the American Medical Association. All the red-baiting language is being used, all the conservative political figures in alliance with them. But the forces in favor of Medicare are also well organized, labor being very important in funding and organizing support. As you can see in the next slide, which is a photo of a big rally in Madison Square Garden supporting Medicare. President Kennedy actually spoke at this rally in favor of it, and that helped build support for Medicare, which grew despite the opposition and despite the familiar language and labeling that occurred against it. As you can see in the next slide, one of the spokesmen for the opposition forces was Ronald Reagan, who speaks out against socialized medicine. But even with that opposition, the forces in favor of Medicare grew, and Medicare was approved legislatively in 1965 and approved along with Medicaid, thus creating this strange system that covered part of the population, but certainly didn't create a universal system, and for many was seen as a caution, an antidote to creating a universal system, because you picked off those who were particularly vulnerable. They would be covered under their own special system, while the rest of the system remained as it had been, provided by commercial insurance, employment-based, and the rest. And yet there were some far-seeing political leaders who saw that they could build on Medicare and began to advocate an early version of Medicare for all and to create a national health program on a single-payer Medicare basis. Among those leaders was Teddy Kennedy, and there was strong labor support. So by the early 70s, there were lots of debates and lots of consideration of a national health program. So much so that some form of national health insurance by the mid-70s was seen as inevitable. The only question was what form would it take rather than whether it would happen at all. But in the 1970s, there were major economic problems. Medicare was built on very foolish foundations. There's a political explanation for that. And there was open-ended inflation. Medicare was seen as a major problem rather than as a model for extension. There were other major problems in the American economy, the oil embargo, and the rest. And all discussions in favor of a national health program ended by the late 70s. So when Ronald Reagan was elected president in 1980, he was, of course, strongly against it. And his admirers, as you can see in this next cartoon, admired the very antithesis that he so vigorously advocated against government involvement in all kinds of social policies, including in health policy. There's health reform, as we would like it, say the conservative political figures. No government involvement, limited government generally. And the Democratic Party at that point was frightened enough by the changed political environment to not even advocate for national health insurance in either 1980 or 1984 in its presidential campaign. The Democratic Party only came back to a national health insurance advocacy in some form in 1988, and that was after Jesse Jackson had led a powerful primary campaign in that year's primary election. Next slide, please. And Jesse Jackson strongly supported national health reform, supported a national single-payer model. This was the time when the Physicians for a National Health Program were becoming an important political force, when that organization took the stage and became a very influential part of the American health policy discussion. Steffie and others can say more about that later if they would like to get to that. But this is the moment in the late 1980s which forces the Democratic Party to start advocating for health reform again, but they do it in a very moderate and middle-of-the-road way. Dukakis is the nominee in 1988, and he has a very different version, not a single-payer version at all, but it can be portrayed as health reform. And then in 1992, Bill Clinton advocates a form of health reform. They are very much not single-payer, not uniform Medicare for all, but they do suggest that there are some ways of getting to national reform. But those approaches get quickly lost, captured in the next cartoon, which is supposed to represent Hillary Clinton leading the task force, getting lost on stairways to nowhere. This, of course, is a takeoff on the famous Escher lithograph. And this shows Hillary trying to follow a map out of the intricate web of health insurance and not being able to find the way out. The Clinton plan implodes. Nothing of any significance comes from it. And what we have in the later 1990s is just a couple of more patches on the American patchwork system, as you can see in the next slide. People debating over which patches to put on the U.S. healthcare system and neglecting to realize that a growing number at that point, 40 million people, are uninsured, and therefore there is a major systemic problem which was not being addressed by the piecemeal measures. Cartoonists pick up the cudgels and I think very successfully start identifying some of the major problems that, of course, PNHP is very vigorously identifying and advocating. This cartoonist in the next slide captures a major problem that PNHP identifies. Do we see a problem, doctor? Yes, there's an insurance company intermediary between the doctor and the patient. And that is not only inefficient, it is also very deflective of any real advance and progress in the American healthcare system. An even more vivid cartoon is the next one, which quite appropriately portrays the health insurance industry as leeches. So the clever remark here is leeches haven't been abandoned entirely in the medical system, perhaps not as therapy as in the old days, but certainly as an integral part of the healthcare system. And by the early 2000s, cartoonists and other commentators are identifying the doublespeak and the self-contradiction and the self-serving language being used by the health insurance industry, as captured in this next cartoon, a brilliant Max Worker cartoon, where we have the representative of Healthy Profits, Inc., good name for an insurance company, which is saying, are you nuts? You want the government involved? That would create bureaucracy, that would create socialism, etc. At the same time that behind them you can see Department of Claims denials, Department of Denial of Pre-Existing Conditions, of relentless advertising. That is the huge, fast, profit-serving bureaucracy that is already upon us in the form of the commercial insurance industry. And this is happening at the same time that Michael Moore produces Sicko in 2007, which was a wake-up call to many and very effectively got some of these same messages across. But the political cartoonists were relentless, as you can see in the next cartoon. There you have the health insurance company draining people of their money, while the individual has been conditioned by this language of anti-socialism and all this sort of fear-mongering to say, I don't want the government in my pockets. Well, of course, the private insurance industry is much more effectively and more deeply in his pockets already and draining of his resources. When actual polls are conducted, and I think this is a very important poll, you can see in the next slide, done by CBS News and the New York Times in 2009, a very significant shift has taken place in American popular attitudes. Whereas in 1979, only 40% of the public polled, represented by the orange, were in favor of a government-provided national health insurance policy. By 2009, 30 years later, that number is close to 60%, 59%, a very important shift in actual attitudes, despite what the insurance industry may be telling you. And similarly, those who thought that private enterprise could take care of things well, back in 1979, 48%, that number had declined to 32%. There is a sea change, and it's a very significant one. Quickly moving forward, the 2008-2009 presidential campaign, we have in the next slide, John McCain running against Barack Obama, offering a tired set of old ideas, tax rebates, no major changes, whatever Obama wants, it's too much, it's not going to do. But in fact, what you can see here, there are more leeches here in the form of the insurance industry, big pharma, HMOs, who are taking their bite out of poor Uncle Sam because there's just, you're adding new resources in the form of the tax cuts, which no systemic change, no important modification in the way this system works, and that's merely going to feed those industries and those particular leeches. Obama comes up with a very complicated scheme, as we all know, the Affordable Care Act. And in the next cartoon, we have a sense of the difficulties that even that plan ran into. There's Obama in the lower left, trying to be professorial and lecture on the bending down of the cost curve. But in the background is a great noise machine, drowning out any attempt at rational discussion, at real debate, and yelling about death panels, but also yelling about socialism and communism and the like, encouraging rage, stoking it up, and really steering people away from any kind of rational discussion. Next slide, another cartoon. When the public option was offered, that was also very carefully assaulted. Their representatives of the health insurance industry are looking out, seeing big signs of socialism. And this is the confuse the public option. They say happily, they know exactly what the dynamic is, how it's working, and why they're very much in favor of it. When the Affordable Care Act is approved, next slide, please, many, especially those in the single-payer movement, see it as a vast compromise and appeasement of the insurance industry. And here is Obama depicted as if he were Neville Chamberlain in 1938 at Munich, saying, we have achieved peace in our time, just as Obama is saying naively, we have achieved health care in our time. But as he's monitoring, as channeling Neville Chamberlain, and is as disconnected from reality as Chamberlain was then back in the 30s about Hitler's real tactics and objectives. We next move to the so-called town hall meetings. Next slide, please, which many have regarded as astroturf rather than real grassroots expressions of political concern and political will that is funded by the Koch brothers and other large industry sources. And placed in those meetings, of course, is the assault on Obamacare, as you can see, equals communism, no socialist health care, and those sorts of messages, again, having political salience because they have a long and sadly effective tradition in the American political environment. It leads to such incredible confusion as this in the next slide, where someone who's saying, I want no part of socialized medicine, Obama socialized medicine, and he better keep his hands off my Medicare too, which is, of course, the ironic confusion. Medicare would be closer to some form of socialized medicine than anything that Obama offered. But this is just the kind of confusion and the insanity that is deliberately manipulated so effectively by the political forces who want to prevent movement towards a national health movement. Just a few slides to finish up. We get to the Republicans starting in 2016 and their repeated attempts to repeal Obamacare, but it's another bit of insanity. Repeal Obamacare shampoo, you work yourself into a lather first, and then you rinse and repeat and repeat and repeat and repeat without success, as it turns out. And the Republicans also, especially under Trump, next slide please, tried to push policies which Paul Krugman has appropriately labeled zombie policies, that the ideas are dead, but they continue to live and they're very hard to put down, such as the advantage of tax cuts for the wealthy, which would then trickle down and benefit everyone. But in fact, what we have are zombies eating our brains without any advance of proper social policy, as this cartoon captures. If we turn to actual trends as the Kaiser Family Foundation has measured in various of its polls, next slide, please. What you need to see here is that those in favor of the Affordable Care Act, are trying to build on it and improve it, are in the upper bar, and those who are against it, the lower bar. There's a lot of overlap and confusion until about 2017, when the Affordable Care Act, its measures were very seriously threatened by the Trump administration and Republicans, and that meant that support began to increase, so that by this last polling date, 53% were in favor of trying to fix or retain the Affordable Care Act rather than do away with it, and 35% were against it. Support is building. And some other polls, we can see a building support to some sort of national program, whether it be a modified Affordable Care Act or more and better. In the next slide, here was a poll that indicated that 57% in 2017 were in favor of public option, 60% in favor of Medicare for all, whereas the opposition was rather small. And in the next slide, it's a little harder to read, but the main thing is it depends what you call it. Terminology is very important. This is a message for political strategy, and I hope this will be taken up in the further conversations during this 3-day forum. If you call whatever you're advancing as a public system, something like universal health insurance or Medicare for all, a very significant percentage of those polled, 63% as opposed to 31%, are in favor as opposed to 31% against it. But if you call it or allow it to be called socialized medicine, that old socialized rhetoric, that labeling, that tarring, that blemishing works effectively as a political stratagem, and support drops down to 46%, just about half and half. And if you call it single payer, I think this is a lesson to be learned here. Only 49% in this Kaiser Family Foundation poll were in favor of it, 32% were opposed, but 19% were unclear. which is the largest unclear or without opinion in this set of polling data, which suggests that a great deal of education has to be done about the single payer terminology and maybe consideration of another terminology. And I'll just leave you with this last slide, and that is, even though you may feel that you're promoting what is absolutely unquestionable, proper, good policy, you've got to be prepared, even if you were Christ himself, to be labeled as a socialist or fascist because you were advocating something as awful as healing the sick and curing the lame. The end of my presentation.
Fantastic, Ted. Thank you so much. It's incredible the way that these leftist terms have been so cynically weaponized and effectively demonized to oppose Medicare for all. I want to quickly remind the audience, if you have any questions for Ted, Anna, or Steffi, please put them in the chat section and we will get to the Q&A session at the end of their presentations here. And with that, I will pass it over to Dr. Anna Malinow to give her presentation on how the system currently operates.
Okay, I need to share my screen. I think that's what it is. We'll see. Nope. Okay.
Apologies, everybody. Just bear with us for just a second here.
Yeah. Do I have screen sharing options?
Andy, can we make sure that she does have screen sharing there? While we get this figured out, I actually have a quick question for Ted that we can maybe do in the meantime. I'm curious how you think that you mentioned the important role that the labor movement has played in pushing for single payer. And I'm just curious, I know most labor unions, or at least a lot of them, do support single payer, but I have seen some labor unions come out in opposition. I was just curious if you could give a brief, how do you think they get co-opted, or why do you think they take that position?
Well, I think it's a very complicated question. I'd like to really hear Anna and Steffi on this as well. But labor movement is not by any means uniform. There are some unions which have strongly supported single payer for a long time, and others who would rather protect what they have now. There's always the fear of losing what you have if you go for something new, and they feel if their membership is sufficiently well covered by employment-based insurance, they don't want to risk losing that, and that might also provide some support for their own labor authority. I think the labor movement is really across the spectrum. There are some very strong advocates for single payer in the labor movement and very strong opponents in the labor movement as well.
Gotcha. And I'll just share a quick anecdote actually along those lines. I volunteered for Bernie in a few different areas in 2020, and one of them was in Las Vegas. I'm forgetting the name of the union that represents a lot of the restaurant workers and casino workers and things on the Strip, but I spoke with someone who had worked with that union, and they expressed to me that I wouldn't believe how much resource and capital and leverage and things go towards negotiating that good healthcare plan, and how much they could improve their workers' compensation and workplace treatment in other areas if they had those resources to apply to those areas instead. Are we set to go here?
Can you see my screen?
There we go. You're all ready to go. All right. Without further ado, Dr. Anna Malinow.
All right. Thank you, Luke. It's a pleasure to be here today to explain our broken system of no system, 100 years of putting this system together piece by piece. Nothing exemplifies our healthcare system better than this cartoon of how single payer was scrapped by Obamacare to become the world's most complicated healthcare system, unless we were to choose the simpler GOP plan, which is simply to get sick and die. As someone once said, a system is perfectly designed to get exactly the results it gets, and our broken, complicated system of no system gets results. We're going to spend the next 30 minutes or so trying to understand the system of no system. First, we're going to look at the big picture, the U.S. healthcare pie, which, as we will see, is messy and stable and varies state by state, but for a few exceptions, is profit-driven. Next, we will take the system apart and look at the individual pieces made up of employer-sponsored health insurance, the individual market, Medicaid, Medicare, and military programs, and sprinkle throughout the Affordable Care Act, also known as the ACA. For every slice, we will have a quiz, And finally, I will challenge you to imagine principles for a healthcare system that is all right, and to keep this in mind as you learn about our broken healthcare system in the next few days. So I like to think of the US healthcare system like a pie cut into slices where we all spend some time in. The first piece, shown here in blue, is the biggest, and where the employer provides private health insurance for their workers and covers about 50% of us. The next piece, shown in orange, is the non-group market, where individuals or individual families purchase private health insurance on their own without the help of an employer. This covers about 5% of us. The next piece, shown in green, is Medicaid, one of our so-called public programs that covers about 18% of us. And the following piece, shown in gold, is Medicare, another one of our quasi-public programs, and this piece covers 16% of us. The dark green represents the military, mostly made up by the Veterans Administration, the most public of our programs, although threatened as well, and it covers 2% of Americans. And that brings us to the last piece, shown in red, the uninsured. I know that I can't see you all, I'm just looking at my screen, but wherever you are, raise your hand if you've ever been uninsured, or if a family member has ever been uninsured, or if a work colleague, neighbor, or friend has ever been uninsured. I'm raising my hand because I was uninsured as a young adult. All my children have been uninsured at some point in time. My guess is that many, many of you are raising your hand right now. So one thing about this
and
pie
I hate to interrupt. I just don't want it to get in the way of your presentation there. Can you hide the bar at the bottom of the screen? I just would hate for any slide to be interrupted there.
Oh, I'm so sorry. Oh, you're right. You
No
told me
problem.
to do that before.
No problem.
Thank you. Thank you.
Yeah.
So, all right, moving on. So this pie looks static, but the truth is that most of us spend our time slipping from piece to piece until we finally happily land on that golden piece of Medicare. Now, before you get too comfortable, I must tell you that every state is different. So there are 50 pies. The Texas pie on the left, you see that the blue employer piece is smaller. The green piece of Medicaid is smaller, which makes the red piece, you see this is just simple geometry, bigger. Now compare this to Massachusetts on the right, where the blue employer piece is quite a bit bigger. The green Medicaid piece is bigger, which makes the red piece, by simple geometry, smaller. Now, the Affordable Care Act, signed by President Obama in 2010, tried to turn every state into Massachusetts. Now, they tried to make the blue piece bigger by using employer mandates, to make the brown piece bigger by enforcing individual mandates that have since been repealed by Trump, and to make the green piece bigger by expanding Medicaid. All this should shrink the size of the red piece, right? The number of uninsured, into a state like Massachusetts. Good geometry, just not good health policy, because we are all still stuck with this pie. So let's spend some time with each piece, asking and I hope answering some questions. This is the blue piece called employer-sponsored health insurance that covers about 164 million individuals in the US. By the way, all the slides have references, so even if it sounds like I'm making stuff up, I'm not. The questions are, how much does this insurance cost employers and workers? Is it affordable to the worker? Have costs gone up? If you work, do you get health insurance? And what is underinsurance and how many people have that? So to answer the question of how much it costs, we go to an index called the Millman Medical Index, which publishes a report every year on the total cost of purchasing a PPO, which is the most common health plan, for an average family of 4, including premiums and out-of-pocket costs, and the cost for the employer. And in 2021, you see that the cost of the average family was a little over $12,000, and the cost for the employer was a little over $16,000. So the total for the year is $28,300. So remember, however, that this that's over $28,000 that's coming out of the worker's paycheck every year. But what does this mean to a worker to pay $12,200 for private health insurance every year? Well, it depends on the family. For starting at the top, for a white family living in DC, the richest area in the country, paying $12,000 means 9% of their income. For the median household in the US, $12,000 is 18% of their income. For the median household income in Mississippi, the poorest state in the country, paying $12,000 for health insurance means 63% of their yearly income. And for someone working for minimum wage, paying $12,000 for health insurance means 77% of their income. Something they couldn't do. So you start to understand how employer-sponsored health insurance can be affordable to some and completely unaffordable to others, even if the employer offers it. Now, to answer the question, have costs gone up, we will look at the cumulative increases from 1999 in 4 different domains. You can see inflation, wages, family premiums, and the worker contributions to that premium. And so starting from the bottom, you can see that since 1999, inflation, which is pictured here in the black line at the bottom, has increased cumulatively since 1999, 47%. Wages, pictured here in the green, have just kept up with inflation and have increased 64%. But in the same period, family premiums, pictured in the blue, have increased 224%, and the worker contribution to that premium in the red has increased a whopping 270%. And this is the reason wages haven't increased. So yes, costs have gone up, even since the passage of the Affordable Care Act in 2010, there shown in the dotted line. So does every worker who works have employer-sponsored health insurance? So this slide is going a little too fast, but we're going to get there. So let's look at the blue bars first, which represent employer insurance for the total population on the left, then to the right, the white population, black population, and then Latinx workers. You can see that almost 60% of all workers have employer insurance, about 65% of white workers have employer insurance, and fewer than 50% of black workers and about 40% of Latinx workers have employer-sponsored health insurance. And it's not because they're not working, because if you look at the mustard bars, that's the percent of the population in the workforce, men, women, and young adults. And you can see that in the total population, more workers work than they get employer insurance. Among white workers, most workers are covered by employer insurance, but fewer black workers and even fewer Latinx workers have employer insurance, despite the fact that Latinx is the community that works the most. They're working all right, they're just not getting health insurance. And for those who do work and have employer insurance, the pandemic uncovered just how tenuous this relationship is, when job losses resulted in millions of individuals losing their own health insurance and that of their dependents. So what is underinsurance and how many people does it affect? Well, underinsurance is defined as spending more than 10% of your income on out-of-pocket health costs. So not your premiums, that doesn't even enter into it, just your out-of-pocket costs. And here we're only going to look at non-elderly individuals because, as we will see, most elderly are covered. So say we're in a room with 100 people. I don't know how many people are here today, but say we're in the room with 100 people. 55 will be insured all year. 23 will be insured, but be underinsured. 10 will have insurance with gaps throughout the year, and 12 will be uninsured. This means that 45 people in our room of 100, or 45% of the people in the US, are underinsured or uninsured. So we should be able to answer our quiz questions now. And that is, we know that it costs about $16,000 per year for employers and $12,000 per year for workers. Well, it's not really affordable to the average worker. Costs have gone up about 270% for families since 1999. If you work, are you automatically covered? Absolutely not. Latinx individuals are much more likely to work than whites, yet are 3 times more likely to be uninsured. And we now know that about 45% of people in the US are uninsured or underinsured. So moving to the next piece of the pie, we land on the non-group market, where individuals purchase their own health insurance, and it covers about 18 million individuals. Our questions include, what is the marketplace, also known as the exchanges? How do you qualify? And finally, how much does this cost? Now, after the passage of the Affordable Care Act with the individual mandate, it became clear that you could not mandate someone to pay 77, 63, or even 18% of their salary on health insurance. So to make health insurance more affordable, everyone would still be mandated to have private health insurance with help from government subsidies that differed according to your income, with the poor getting more subsidies than the non-poor, subsidies that went straight to the insurance companies, making them billions of dollars richer. And we know what they do with their money. No, not to improve care, but to pay for their own exorbitant salaries and buy members of Congress to vote against single payer. But I get ahead of myself. Now, to purchase these policies, you must go to a website that has 1,700 state rules to determine eligibility and how much you need to pay according to the level of coverage you choose, because you can choose the different, silver, bronze, so forth. Now, the first cartoon we saw was not an exaggeration. What I'm showing you on the right is not a cartoon, it's for real. So how does this work? Well, there is this handy calculator from the Kaiser Family Foundation website where you can plug in your state, and I just put in the US average, how much money you make, and I put in 67,500, which is the median household income in the US. And I also added that this was a family of 4 with 2 young parents and 2 young children, none of whom smoke. I hit submit, and presto. You are told that your family earns 258% of the federal poverty level, and that you will get $1,159 in financial help, which goes straight to the insurance company, and you will only pay $242 per month, which should be only 4.31% of your annual income. But what they put in very, very, very small print is that you're in network. Okay, we're talking about in network, out of pocket max, meaning if you actually use healthcare that year, will be $17,000, which is really 25% of your income. So, answers to our questions. The marketplace was created by the Affordable Care Act to let people enroll for private health insurance with government subsidies. You qualify based on your income, your age, your gender, your family composition, and your geographic location. It's affordable maybe until you need health care. So moving on, we find ourselves like 83.6 million people in Medicaid. A small asterisk reminds me to mention that there has been an increase of over 12 million people since the start of the pandemic due to the Families First Act, which banned states from involuntarily disenrolling beneficiaries during the public health emergency. Yeah, because that happens. This will become clear in a minute. So our questions are, who qualifies for Medicaid? What is the federal poverty level? Can you lose Medicaid? Has it reduced the uninsured as proposed by the Affordable Care Act? What is CHIP? And what about children? So Medicaid is a federally and state-funded program administered by each state, which makes eligibility and benefits vary widely from state to state. It is means tested, which means that you have to prove your poverty, and depends on the family's monthly income, which can vary month to month, as many people on Medicaid do. As I mentioned, the Families First Act banned this type of disenrolling, but once the public health emergency is declared over, which is going to be very soon, up to 15 million individuals, including 6 million children, are at risk for losing their Medicaid. While we think of Medicaid as being public, the truth is that up to 70% of all Medicaid beneficiaries are managed by private health insurance companies. Now, let's see what it takes to qualify for Medicaid. Now, remember, every state is different, and we will look at Texas, not because it's the worst state, but because it is a state that has not expanded Medicaid. So let's look first at the dark green bars, which represent people on Medicaid. It starts with your monthly income according to 100% of the federal poverty level, shown here by the red dashed line, which in 2021 for a family of 4 was $26,500 per year. Now, if you look at the x-axis, that's the horizontal axis, you can also see it depends if you're a child, and if you're a child on your age, if you're pregnant, if you're an adult with children or without, if you're on SSI, and if you're over 65 for long-term care. Now let's take a look at the green bars. In Texas, if you have a child under the age of 1 and your family makes under $4,500 per month, your child will qualify for Medicaid. But the day your child turns 1 to 5, the family must make under $3,300 per month for the child to qualify. And once your child turns 6 to 18, the family must make under $3,000 for your child to qualify. Mind you, a family can have 3 children, all different ages, all different monthly income requirements. Now moving on, if you are pregnant, your family of 4 must make under $4,500 for you as a pregnant woman to qualify for Medicaid. And if you're an adult with children, you must make under $375 per month. You heard me. $375 per month to qualify for Medicaid. Now, in states that did expand Medicaid, adults can make up to $3,000 per month to qualify, but not in Texas and not in the 11 other states which have not yet expanded Medicaid. So if you're an adult moving on without children in Texas, you do not qualify for Medicaid. If you're on SSI, you can make up to $1,600 per month to qualify. And if you're over 65 and you make under $2,500 per month, Medicaid will pay for your long-term care, but you must give every penny to Medicaid, except that they let you keep about $40 a month. Now, CHIP, or the Children's Health Insurance Program, was passed to cover those children whose parents made it too much for Medicaid and not enough to pay for private insurance. Every state is different, but in Texas, as you can see in the light green bars, it covers all children through 18 whose parents make 200% of the federal poverty level or less. As you can imagine, except during a pandemic, there's plenty of churning, which means coming in and out of Medicaid because you make slightly more money one month compared to another. About 55% of pregnant women lose their Medicaid within 6 months after giving birth because in most states, eligibility ends 60 days after giving birth, and many of them no longer qualify as adults. So, to answer the question, did the expansion of Medicaid reduce the number of uninsured? We will compare two states. West Virginia, a poor state, which expanded Medicaid, and Texas, not such a poor state, which did not. Now, the blue bars represent the percent of people covered by employer insurance. You can see that fewer people are covered by their employees in West Virginia compared to Texas slightly, but because many more people in West Virginia are covered by Medicaid, those are the green bars, compared to Texas, fewer people are uninsured in the red bars than they are in Texas. So these are the 12 holdout, mostly southern states that have not expanded Medicaid. This is what happens when you allow states to decide health policy. Now, what about children? About 40% of children in the US are covered by Medicaid. Here, we look at the insurance coverage for white, Latinx, and Black children, and the blue bars represent children covered by their parents' employers, and you can see the difference between white, Latinx, and Black children, just like their parents. Shouldn't be a surprise. The green bars represent Medicaid, and you can see the difference between white, Latinx, and Black coverage for children, and as a result, few white children are uninsured. Those are the red bars. But more Latinx children are uninsured, and Black children, because they qualify for more Medicaid, have fewer uninsured. And overall, about 5% of children are uninsured. So to answer our questions, our quiz questions, we learned that qualifying for Medicaid depends on your age, if you're pregnant, your state, your disability, and income. The federal poverty level for a family of 4 is $26,500. You can lose it because it's month to month. Does it reduce the uninsured? Yes, it has in those states that have expanded Medicaid. And CHIP is the insurance program for children whose parents make too much to qualify for Medicaid and not enough to pay for private health insurance. And children's access to care is tiered and racially segregated. Now we're on to Medicare, where 57 million people get their health coverage. Our questions are, what percent of seniors are covered? And when do you qualify? And is it simple? And does it cover all your healthcare costs? Well, if President Obama, when he was designing the Affordable Care Act, really wanted to lower the number of uninsured to zero, he could have looked at this graph from the US Census that shows us the percentage of people without health insurance before and after the ACA. Remember, the Affordable Care Act was passed in 2010, but fully implemented in 2014. So the percent of uninsured among non-elderly adults in the blue line did go down, as did the percentage of children without health insurance in the middle line. But for seniors, it stayed pretty much at zero. The way to cover everyone is to expand Medicare to everyone. Medicare, as most of you know, and especially after Ted's talk, was passed in 1965 to cover the elderly. It is our one single-payer system, which is publicly funded through payroll taxes and general revenue, and it is privately delivered. It is automatic for people when they turn 65 and covers individuals also with end-stage renal disease, ALS, and some people with disabilities. It is not simple. Surprise. My brother, as an aside, has an MD, PhD, and today he told me that he needed to get, he just turned 65 and told me that he needed to get a Medicare PhD because he can't figure it out. So half of seniors choose to stay on traditional fee-for-service Medicare with 2% administrative costs, and this is at risk for being privatized. And the other half choose Medicare Advantage, private insurance companies to manage their care, costs more than traditional Medicare and has higher administrative costs, and already is fully privatized. Now, let's look at traditional original fee-for-service Medicare. There is Part A to cover hospital costs, Part B that covers 80% of outpatient costs, and Part D that covers prescription drug costs. Each part has premiums and deductibles. Most seniors purchase a private supplemental plan to cover the uncovered 20% costs, and still Medicare only covers 2/3 of all healthcare costs, has out-of-pocket costs for seniors, and does not cover hearing, vision, dental, or long-term care. So this is not the kind of Medicare for all we're talking about. So our quiz answers. We see that almost all seniors are covered by Medicare when they turn 65. It is not simple, and it covers only 2/3 of all healthcare costs for seniors. Now, almost all public program in the US is the Veterans Health Administration, which covers 9 million veterans. It is fully integrated, mission-driven, rather than profit-driven system. It is the only socialized system, ironically, where all providers are salaries. It is fully integrated. It covers all necessary medical care and is quite comprehensive, covering prescription drugs and long-term care as well. There are eligibility criteria for vets, which unfortunately exclude more than half of all vets, but it is free at the point of care with minimal copays for certain vets. And just like every other program, every other public program, it is facing serious efforts to privatize the entire system. And we finally arrive at the piece of the uninsured, which covers almost 10% or 30 million of us. In addition to asking how many are uninsured, we also ask who are the uninsured, although many of us have already been uninsured or are uninsured, and what are the consequences of being uninsured. This graph shows the uninsured by race and ethnicity over time from 2010, before the implementation of the Affordable Care Act, to 2018, after the full implementation of the ACA. And you can see that while the Affordable Care Act did result in a decrease of the uninsured, there are still 30 million uninsured. The decrease was not equal between races and ethnicities, and certainly not zero. Now, as you can see from this bar graph, from the US Census on the right, anyone can be uninsured. I know it's sort of small, but I'll just tell you what I can see, especially Latinx, non-citizens, all workers. What we know is essential workers, which are in that box on the left. If you are separated, if you live in the South, or in a state that has not expanded Medicaid. So most people who are uninsured work, as you can see in the pie graph on the left. 75% have one or more full-time workers in their family. Most are poor. They live under 100% of the federal poverty level, and most are white or Latinx. Now, while being uninsured decreases your chances of visiting a doctor or paying for prescription drugs, it can have fatal consequences. The flu season of 2019 to 2020, and that was the year before the pandemic, 20,000 people died from the flu. That year and every year, 35,000 people die from being uninsured. So our quiz answers, how many are uninsured? About 30 million people are uninsured. We know that people from all walks of life can be uninsured, particularly workers, mostly poor, all races, but especially white and Latinx. And the consequences of being uninsured in the US is dying unnecessarily. So, next question is, how much does this pie cost? How do we compare to other countries? Is our healthcare system equitable? Are we getting our money's worth? And who profits? Well, compared to high-income countries, such as the UK, Japan, Canada, Germany, and Switzerland, as you can see here, we outspend every other country except Switzerland by twice as much. We still outspend Switzerland, but not by twice as much. Now, spending $12,500 per person per year adds up to $4.1 trillion spent on healthcare in 1 year. To give you a scope of 4.1 trillion, there are 3.1 trillion seconds in 100,000 years. You could spend $1 every second for the next 100,000 years, and you'd still not spend $4.1 trillion. Now, why do we spend this much? Well, compared to other high-income countries, we are younger. We don't smoke as much. We don't drink more, but yes, we are more obese, but many other countries have obesity as well. So it's not because we have more risk factors that our healthcare costs are high. And despite outspending every other nation and not having more risk factors, compared to other countries, the US has, the lowest percentage of people covered, the lowest life expectancy, and worst maternal, infant, and neonatal mortality. In comparison, we have equal health force, same number of hospital beds, and equal rates of utilization, but we do have significantly greater administrative costs, spend lots more on prescription drugs because the government doesn't negotiate with pharmaceutical companies, and our prices are much, much higher. Compared to other high-income countries, shown here, the US has had the greatest number of deaths from COVID per million people. You can see there the latest wave, the United States on top. And we know this has affected communities of color unequally. The risk of hospitalization from COVID has been 2.4 times greater among Latinx communities and 2.5 times greater among Black communities compared to white. And the risk of death from COVID is almost 2 times greater among Latinx communities and 1.7 times greater among Black communities. And why? Because we have a system of no system based on profit. This is an article from the New York Times early on in the pandemic. It was August of 2020, when rural hospitals were struggling, small physician practices were folding, and healthcare workers were being furloughed. And all the while, hospital chains and insurance companies were making record profits from taxpayer dollars. And the combined pre-tax profits of vaccine makers Pfizer, BioNTech, and Moderna will be over $1,000 per second. So to answer our quiz, 2 years ago, we spent $4.1 trillion on healthcare, twice the average of most high-income countries. We are not getting our money's worth, and corporations and not patients are profiting. Now, imagine you and a group of your best friends were given $4.1 trillion to design a healthcare system worth $4.1 trillion. What would be your non-negotiable guiding principles? My guess is that healthy profits would not be one of them. So I've given this talk a bit, and I usually ask my audience to come up with a list of 5 to 6 guiding principles. And after giving this talk for over 100 times, every time everyone comes up with the same list: universal, comprehensive, sustainable, accessible and free at the point of care, gender affirming, high quality and evidence-based, and equitable. It shows me that we all agree on what we want. Now we just have to agree on how to get there. And this is how we get there: with national single payer health, or national single payer health program, because everyone has the right to health care. Now that you hopefully understand our broken healthcare system, how all the pieces fit together, how it is expensive because it's based on profit, we can fight for the system we deserve. Healthcare is a human right, and healthcare should be for people, not for profit. I invite you to come up with your own list of non-negotiable guiding principles and think about these principles as we participate in the summit. I'll be referring to these again as we wrap up on Sunday. I would like to finish with thanking all the patients who, over 30 years, have given me the inspiration to fight for single payer, the mentors who gave me the tools to fight, and the activists who have helped me along the way. So I will hand it over to Dr. Steffie Woolhandler, who has been one of the wonderful mentors who has given me the tools to fight. Thank you, everyone.
And if I could just cut in really quick, just one more time, I want to remind the audience to put questions in the chat if you have any questions for our wonderful panelists today. And Dr. Woolhandler is going to go over the harms from privatization. So here's Steffie Woolhandler on her presentation.
Yeah, hi, Andy. Can I have? Oh, great. Okay, I'm going to be talking about the pitfalls of privatization. And it's a bit the question about, would Medicare Advantage, that is private insurance for all, be just as good as a real single payer Medicare for all program? Next slide. Now already our taxes are funding about 2/3 of health spending. So Anna was showing where people got their coverage, and it looks like the government piece is small, but that's not really true, because when you look not at people who have these different insurances, but where the money comes from, you get a pie that looks like this, where you have Medicare, which is taxpayer funded, Medicaid, VA, public health in white, government worker benefits. I now work for the city and state of New York. They pay benefits for me out of tax dollars. The so-called tax subsidy to private insurance. It turns out that at the funding level, the majority of the funding for the healthcare system already comes from public payers. Next slide. This relates to the fact that private health insurance, by which I mean privately purchased, privately funded health insurance from private insurers, that has actually shrunken. Used to cover over 80% of the population, and currently private sector private coverage is really only about 65% of the population covered at most. Next slide. So how come private insurers have so much money, you know, and they're getting bigger and stronger if there's a shrinkage of like commercial private insurance? Well, it turns out the government turns over a huge share of taxpayer dollars to private insurers for health care. A, a bunch of the money for private insurers comes in that bright yellow slice from private employers and private households. But a chunk of it also comes from city and state of New York, who pays for benefits for me, or federal government and state and local governments that purchase health benefits for their workers with public dollars. And there's Medicare, which is most funneled through private insurance through the so-called Medicare Advantage program, and managed care Medicaid money that's turned over to private insurance companies to run the health plan. Next slide. So what we're coming to is a corporate-run managed care system that is going to replace both fee-for-service care and nonprofit managed care. So we have privatization, which is really corporatization, moved to a private profit-oriented system, largely structured around managed care. Next slide. Now, some of you, I think, are probably in Southern California. You're probably not thinking about where your water comes from, but it turns out the water you're drinking actually comes from a long way away. The Hoover Dam out in the mountains. It goes through uh, uh, Arizona, all the way across the country. And next slide. And this is what the Hoover Dam actually looks like. It's out in the middle of the freaking desert, right? Um, next slide. Now, it was built on a government contract by Kaiser Steel that had a bunch of workers out there in the middle of the desert, including building that giant aqueduct that goes all the way from Arizona to Los Angeles. Next slide. And there was a problem with this, which there were workers out in the middle of the desert. There was no health care. So Kaiser Steel put together a plan to put clinics and hospitals out there in the desert for the people working on the Hoover Dam. So that's the origins of managed care in this country, the origins of Kaiser. But when I mean out in the desert, I mean it. Next slide. This is actually Desert Center, California, which this was physically the site of the first Kaiser hospital. Obviously, there's nothing there now, and there was nothing there before the hospital, and there's nothing there now. So this was a model of managed care, not that it was going to make profits in its own right. It didn't make profits. It was all nonprofit, right? But it was going to assist Kaiser Steel in making profits by providing health care for the workers. Next slide. And that model, next slide, please. That model of managed care stuck around until in the 1970s. A man named Paul Elwood put together the idea that an HMO, managed care, could be a profit-making entity in its own right, not just something to serve other profit making. But the HMO would agree to provide comprehensive health maintenance services to its enrollees in exchange for a fixed annual fee. The economic incentives of both the provider and the consumer would be aligned, and you could actually make money off of an HMO in its own right. Next slide. Now, this was put in place and advocated over the years despite substantial and relatively early evidence that high-risk people do not do very well in the HMO setting. And these are the results from the Rand Health Insurance experiment that was done in the 70s with $100 million of federal tax money, where people were randomly assigned to HMOs versus fee-for-service care. And among people with even minor health problems like high blood pressure, those in the HMO had an elevated risk of dying, represented in the slide by the 1.21. That's a 21% increase risk of dying relative to people in a free fee-for-service system. It turned out it was because their blood pressure was poorly controlled. But we did know very early on that if you have a medical condition, it's not a great idea to be in the managed care setting. Next slide. And this is particularly true in another study, the medical outcome study, that looked at mentally ill people. That I'm not going to go through the slide, but it'll be available to you. But it turns out if you're depressed or mentally ill, you're much better off in a free fee-for-service system than you are in a managed care system where they're trying to save money by not giving you care. Next slide. And this is an audit that was done. It's a federal audit, again, looking at managed mental health care, which was really outrageously bad for mentally ill people. The managed mental health plans overstated how much care they gave. They delayed referrals for mental health services. They'd enroll people and then have no mental health providers in 15% of the counties where they enrolled people. Again, this is known. This is not some secret that the managed care was doing a very poor job with people with expensive medical needs. The managed care was maybe okay if you were healthy, but if you really had medical needs, there was good evidence that it was going to fail. Next slide. And this was kind of summarized in this, rather cynical cartoon. Your HMO is paying me big bucks to hold down your treatment costs. You want to make me a better offer. Next slide. So doctors were pulled into this. Again, despite the doctors saying they knew that capitation was cutting their use of needed services. This is actually doctors being asked with vignettes about, does the patient need the service? Would you give them the service if they had regular medical care fee for service? Would you give it to them if they had capitation? The doctors knew that the capitation was cutting care that people needed. Next slide. And similarly, when he asked doctors, do you think capitation, paying a set fee and running managed care, is that ethical? Really a very high proportion of doctors will say it's a conflict. Capitation is a conflict of interest. It's unethical. Many of them also feel it was unavoidable and probably, unless we change the system to a single payer, will continue to be unavoidable. Next slide. Now, it turns out that most managed care currently is kind of a hybrid. It kind of looks like fee for service, but it really is managed care. So the doctor might get some payment for seeing the patient, but in order to get their bonuses that bring their salary up to par, they're going to have to manage the care and cut back on the care. Next slide. And this is actually material from my own contract that I had with U.S. Healthcare. It actually became Aetna, and now it's CVS Aetna, but at the time it was called U.S. Healthcare, and I had a contract. And it said that my income as a primary care doctor would be based on the number of hospital days my patients had, the number of specialty referrals where I'd get more money if they had less referrals, number of ER visits, I'd get more money if I didn't let them go to the ER, and some certain quality and loyalty measures. And if I didn't get any of the bonuses, if I just ignored the managed care aspects, I would earn about $123,000 a year, which sounds good until you realize that's the cost of my overhead to run a practice, about $123,000 a year. So really, in order to make any salary for myself, I would have to make the bonuses. I would have to participate in the managed care elements and cut back on my patients' use of hospital days, specialty referrals, and ED visits. Next slide. Well, my partner, David Himmelstein, was also in the U.S. Healthcare, and he published the contract provisions along with me in the New England Journal of Medicine, saying we thought it was unethical. And he got this letter saying that he was fired from U.S. Healthcare and he couldn't practice there anymore. And actually, there was a bit of an outcry about it. Next slide. And it ended up being in Time magazine. This is not a picture of my partner, but they found like a model or something. But there was a scandal about doctors being gagged and told they couldn't share the conditions of their contract, even when those conditions might hurt patients. And actually, he was rehired. Next slide. But unfortunately, HMO retribution to doctors for providing high-cost care did not end, and Aetna Health Plans did name this gentleman, I know his name, but it's his initials. He was named Primary Care Physician of the Month 1 month, and then literally 2 months later, they fired him because he exceeded the guidelines for cost per patient. He was too expensive. Next slide. Okay. So Medicare HMOs, like HMOs kind of got a bad name and people don't use that a whole lot anymore. So Medicare HMOs, which are private plans that provide managed care to Medicare enrollees, have been rebranded as Medicare Advantage, but I'm going to use those terms interchangeably. Next slide. And there has just been this tremendous growth in Medicare HMOs or Medicare Advantage. Remember, this is all taxpayer funded. This is our taxes paying for this. And they've just exploded. And they're expected to actually, unless we do something about it, to fully take over the Medicare market over the next 5 years or so. Next slide. Now, this is really remarkable because if we look at the efficiency of traditional Medicare on the left, in terms of how much money is spent for medical care and how much goes to overhead, traditional Medicare only has an overhead of 2%. Medicare Advantage, on the other hand, has an overhead of 6 times that much, about 14%. So you would think that traditional Medicare ought to be able to outcompete Medicare Advantage in the marketplace. Next slide. And just again illustrating this got even worse during the pandemic, where Medicare Advantage during the pandemic was collecting overhead for every senior they enrolled. They were collecting overhead of $2,200, almost $2,300. So, something like 20% of everything Medicare spent on private Medicare Advantage plans ended up in the pockets of private insurers. That's the middle set of bars. Okay, next slide. But as I said, despite traditional Medicare's lower overhead, Medicare Advantage plans outcompete traditional Medicare, and they do that. And I misspelled and had some typos here, by gaming the payment rules. They learn the payment rules, they game the system, and they adapt very quickly when the payment rules change. They also game the system by cherry picking, upcoding, lobbying, and overpayment. I'm just going to briefly go over what all that means. Next slide. The main thing it means is you become good at cheating and you never need to become good at anything else. That's a Banksy quote. Next slide. Okay. Well, managed care has really moved from its exclusive focus on restricting care as its only profit-making strategy to cherry picking and lemon dropping. And I think you probably know what cherry picking means. Next slide. Picking the most profitable patients and getting rid, but you may not know what lemon dropping means, which means getting rid of the ones who are costly. But to explain this briefly, it turns out that healthcare spending is very lopsided, with 20% of all private insurance enrollees spending 80% of the money that private insurance spends. What we're saying is that the 20% of people who are sickest in any given year are consuming most of the medical care. And that's probably true of you if you've ever been hospitalized. The year you were hospitalized, you used a lot of medical care. Most other years of your life, you don't consume much. But it turns out that if you're an insurance company and you're able to selectively recruit those people who are sickest, deciles 9 and 10, who use the most healthcare, you're selectively able to recruit people who are not the sickest, everyone below that, deciles 1 through 8, and selectively drop people in deciles 9 and 10, you can actually make a lot of money. So cherry picking means picking the low cost people. Lemon dropping means getting rid of those high cost people. Next slide. Okay, so Medicare Advantage programs, HMOs, have been very effective in doing this. So if you graph the average Medicare spending in yellow on the left, which is the basis of the payment to Medicare Advantage, average Medicare spending, it turns out that the people who Medicare HMOs enroll had lower costs the year before joining the HMO. So the HMO cherry-picked enrollment got lower cost people. Yet in the 3 months after leaving an HMO, Medicare HMO, and coming back to traditional Medicare, the spending was nearly twice as high as the average for Medicare. Lemon dropping, cherry picking, and lemon dropping. And this is an older study in New England Journal, but next slide. It's still going on today. Even with risk adjustment, the HMOs are able to game the risk adjustment system and cherry pick people within any given diagnoses who are not as sick as other people. So they can cherry pick someone with very mild diabetes, call them diabetic, and avoid someone with very severe diabetes. Next slide. And we see very clear evidence of lemon dropping when we look at the disenrollment, people who are forced out of Medicare Advantage, low needs patients stay in Medicare Advantage, high needs patients are forced out. Next slide. How would you do this? Well, what the Medicare Advantage plans have all started doing is making you pay something called co-insurance if you have chemotherapy. Co-insurance means you as the patient pay a share of the total cost, not $5, not $20, but some percentage of the total cost. And with many chemotherapies, new chemotherapies costing hundreds of thousands of dollars per year, if you force people to pay a 20% co-insurance, they're out of pocket a very, very large amount of money. And those people will leave your Medicare Advantage plans if they can to try to find a way where their cancer chemotherapy is more affordable. So you can use benefit design, structure the copayments, deductibles, and coinsurance in order to make it extremely difficult for people with high cost illnesses to stay in your HMO. Next slide. Okay, so managed care has, just to the other point, they've moved from primary care restriction to other mechanisms. I talked about cherry picking and lemon dropping, but they've also moved to aggressive use of overcoding and overdiagnosis. Next slide. All right. Now, why does a Medicare managed care so much about overcoding and overdiagnosis? And these are a list of diagnoses that apply to the same patient. It's one patient here, but there's two ways of coding it. If you say this person has diabetes mellitus, chronic kidney disease, obesity, depression, chronic uh, coronary artery disease, you only get $5,000, okay? If you describe the same patient with slightly different words, say they have diabetes mellitus type 2 with diabetic chronic kidney disease, they have chronic kidney disease stage 4, they have morbid obesity rather than just obesity, major depression rather than depression, coronary artery disease with angina rather than chronic coronary artery disease. The same patient described with a different set of words, and now you get a payment like an annual premium from the taxpayers for this patient of $17,000, more than $17,000. So upcoding, sometimes upcoding, but overcoding is immensely profitable. Next slide. And when a patient joins a Medicare HMO, the risk score, the number of diagnoses reported, is that blue line, and it just starts to soar. Lots of things are listed as diagnoses that were either unimportant or listed in slightly different language before, but that causes the cost to the taxpayers to soar. Next slide. Okay. Now, you may be sitting there going, well, this doesn't quite make sense because don't we have these medical loss ratio rules about, how much money the Aetna, for instance, can make? Why would they keep upcoding and upcoding? Well, it turns out the emerging model right now is I call the CVS Aetna model. CVS actually merged with an insurance company, and now the insurance company essentially owns the doctors. So there are no longer any medical loss ratio rules because you can just mush the extra money into your doctor subsidiary. And next slide. This is being done by a lot of other insurers. United Healthcare is does something that they have a special name when they mush the money from the insurance part to the doctor part. It's called an intercorporate transfer, but it's just gone up and up and up over the years as a way of getting around the medical loss ratio rules that were put in place with the ACO. Next slide. Okay. Now, Medicare Advantage plans sometimes just claim diagnoses that they don't even mention in the chart. This is a CMS audit, a federal audit showing literally billions of dollars paid out by the taxpayers for diagnoses that the Medicare HMO reported to CMS in order to get this high premium and then never even wrote down in the chart. Next slide. Okay, now consequently, and this is 20 from old data, this is 10-year-old data, so you have to keep that in mind. But consequently, if we compare the spending, the cost of traditional Medicare versus the cost of Medicare Advantage, the blue part is the part of the premium that actually goes during a month for medical care. And you'll see the traditional Medicare spends more on doctors and nurses and drugs or whatever. But the overhead, the yellow part of the spending is so much higher in the HMOs that the total cost to the taxpayers is actually higher in the Medicare HMO. That is, the taxpayer is spending more for less care, the difference being eaten up as overhead and profit. Next. Okay. Consequently, Medicare Advantage has raised the cost to the taxpayers year upon year upon year. This is from the Medical Policy Advisory Commission of the U.S. Congress. Next. Okay. So what happens with all this overpayment? Well, only a tiny share of the taxpayers' extra payments actually benefit seniors. So if you have a Medicare HMO, you might be able to get free reading glasses, but most of that money, that's an extra benefit. That's good. But most of the money ends up in the pockets of the insurance industry. Next slide. Now, what are accountable care organizations? Well, accountable care organizations are a managed care strategy for turning your local hospital into a managed care organization by creating managed care incentives for them. And Medicare has been leading the charge with this. Next slide. There's been a huge growth, explosive growth of ACOs. Next slide. And the ACOs use the same tactics as other managed care, or many of the same tactics, including lemon dropping of high cost patients. Because of the ways ACOs are paid, it's harder for them to cherry pick, but it's very, very easy for them to lemon drop. And when we look and see, who left the ACO versus who stayed in the ACO, the ones who left were the higher cost patients. They were higher cost by at least $1,000. Next slide. Another slide. Well, how would you get rid of high cost patients? Well, one way is to fire their doctors. So if you have doctors like I told you, Dr. GS, who was at Aetna, who just happen to have a lot of breast cancer patients or seriously ill patients, you just fire the doctors. And this slide is actually just showing that's exactly what goes on. If a doctor is a high cost doctor, either because they're just profligate or because they have a lot of expensive patients, 30% of them are forced out of the ACO in the course of a year. Next slide. And just despite there's been a lot of hoopla about we're going to save all this money with ACOs, the savings have it. This is data from CMS, from the federal government. At most, $1 billion been saved over 7 years. That's like 140 million, which is less than rounding error in healthcare. It's a $4 trillion business to say, oh, we saved a lot of money. Maybe we saved 140 million a year. It's just that's a ridiculous thing to say. It's really rounding error. Next slide. The latest kid on the block, and Anna Malinow's played a big role in publicizing this, are so-called direct contracting entities, and this is likely, if allowed to go unchecked, to fully push Medicare into the hands of private insurance companies. Those what what it does is for people who enroll in traditional Medicare who say, I don't want the managed care, it automatically assigns you to direct contracting entity that's paid capitation, similar to a Medicare Advantage plan. Some of these are owned by insurance giants, direct contracting entities. Some are owned by these for-profit startups, like Apple Care, Oak Street Medical, that are collecting huge amounts of money from Wall Street. As with Medicare Advantage, overdiagnosis and upcoding is key to profitability. You can overdiagnose people, raise their risk score, uh, write down a bunch of diagnoses that are not meaningful, raise the risk score even higher, and then get the taxpayers to pay you a big fat premium for someone who's not necessarily all that sick. And consequently, some of the successful DCE entities are being valued by Wall Street at as much as $87,000 per enrollee, because the promise of being able to just bilk the taxpayers through these upcoding games is kind of irresistible. Last slide. So to summarize, why does the Medicare for All movement need to focus so much on privatization? I mean, wouldn't it just be great to get everybody some sort of insurance? Well, at some level, yes. But privatization in this way would raise costs to the taxpayers. We know that because that's what's happening in Medicare Advantage. It would restrict the care for the sickest and highest cost patients who need it most, right? It would divert health spending from care to corporate profit, and it would subvert the public accountability and control of health care, even the limited amount that we have now, by placing medical care entirely into the hands of corporate entities. Okay, so that's it for me. I guess we have just a few minutes left, but you could.
Thank you so much, Steffi. Fantastic presentation. It's incredible how we hand this system over to people who seem to be more in the business of dodging providing healthcare than they do actually providing it. I do just want to note those last two presentations, we got into some of the funding stuff, and we are going to be talking on Sunday in a panel at 4 Eastern, 1 Pacific about the funding mechanisms and MMT and how the federal government actually goes about funding these federal programs. So make sure not to miss that one if you were interested in a deeper dive into some of the funding that Anna and Steffi were just talking about. We'll go ahead and kick off the Q&A. We have a question from Lee Stanfield. Lee asks, how much of the high cost of U.S. healthcare do the panelists attribute to feed for service, and how much to administrative costs? If any of you want to go ahead and jump in on that one.
Well, I'm going to take that first. You can control costs under fee for service. We know that because many countries with single payer or other forms of good national health programs do have fee for service and are able to control costs through other mechanisms, what we call supply side control. I'm not in love with fee for service. I don't think it's a great system, but that is not the cause of the high costs in the U.S. And the managed care industry would have us believe that there's no way to control costs without corporate care managers in there. That just simply isn't true.
Yeah, the only thing that I would add is that when you compare our utilization rate, for example, with other countries, we don't use healthcare more. It's just that it costs more here. So it's if we got rid of fee for service, we would not be controlling costs anymore. In fact, it would even be worse because we're seeing the evidence from Medicare Advantage and managed care that in fact they raise costs rather than control them.
We have one more from Lee Stanfield as well. He asked, Kentuckians for single-payer healthcare want to know, would the public option actually move us forward? I've heard both opinions on this, that it could act as a poison pill for our movement and that it could be, in some micro sense, a step in the right direction. I'm curious what you all might think.
Well, I'm happy to give my opinion. I mean, public option, if you're going to go into the exchange and buy insurance, it would be nice to have another option, right? But it was always seen as just part of the Affordable Care Act. And I think a public option would run into a lot of the same problems competing with private insurance that we've seen in Medicare Advantage competition. If the private insurers are willing to cheat, they're willing to lemon drop and push all of the high-risk patients off into the public option, then your public option just becomes a high-risk pool. with very high costs, and it raises the cost of the system. So I'm not opposed to public option, but I don't really think it gets us very close to Medicare for all.
Well,
Ted or Anna, anything to expand on that?
I
I don't know, Ted. No, Ted, go ahead.
I would agree. I think it's just a deflection from what the real political issues are.
Right. It's a little bit of a death spiral. Basically, it's making, right now, the government takes care of the oldest and the sickest and the poorest, right, through Medicare and Medicaid. And having a public option is just going to make the government take care of even more sick patients as well, because that's what's going to happen. The private insurance companies will be lemon dropping and cherry picking the healthy ones. They're really, really good at that. We know that.
Yeah, absolutely. And then I had a question. I can start it off with Ted, because you talked a lot about how the media and you know, some of the cartoonists and things talk about these issues. I'm just curious how you might advise the audience to look out for the kind of propaganda that you were talking about, and how to maybe contradict it. I know a couple of you had talked about the specific terms that we use when we promote this policy. What do you advise to those who are digesting media about healthcare policy?
Well, just stay alert. There are certain trigger words that are used again and again, sometimes disguised, but sometimes direct, and try to see through them and expose them for the purposes behind them.
Absolutely. And then one other thing I wanted to make sure to ask Anna about, actually, because I've heard you talk about this before. I can't remember if you mentioned it today or not, but it's incredible to me that patients can be moved from public systems to private systems, sometimes without even their knowledge of that occurring. Can you talk about that and how maybe a patient can go about ensuring that they actually understand what their, you know, what their setup is, how they're engaging in our healthcare system?
Well, you're describing direct contracting entities, which have been rebranded by CMS as ACO REACH, but they're exactly the same. In fact, they're probably worse. They are these middlemen that are owned by private equity firms and venture capital firms and commercial health insurance companies in order to, they're middlemen in order to lower costs, right? I've never known a middleman to lower a cost anywhere, but this is like hope that springs eternal here. We'll keep doing the same thing over and over again. But how were seniors enrolled is like the most nefarious part. Well, one of the most nefarious parts of this whole system. These are, just as Steffie was saying, these are individuals who have rejected Medicare Advantage and they want to stay in traditional fee-for-service Medicare, right? They do not want an insurance company messing with their care or managing their care. And yet, without their knowledge or consent, they are being enrolled into these direct contracting entities or ACO REACH. And the way that it's happening is that with Medicare Advantage, the insurance company tries to recruit the patient, right? You know, we're bombarded during the open enrollment or open season, as I call it, with Medicare Advantage plans. But with DCEs, they don't try to recruit the patients. They recruit the physicians and the physician practices and the health and the hospital systems. So that's where they go to. They go to the physicians and physician practices. And once the physician joins, then all of their patients come along with them. And so once the physician joins the DCE, then all of their patients automatically become part of that DCE. Without their knowledge, without their consent, they get this letter or this notice once a year to tell them that they are now part of the DCE. And what can they do about it? Really not much. In fact, I asked Liz Fowler, the director of the CMMI, specifically this question: what if a senior doesn't want to be in a DCE? And her answer was, just find another doctor.
Can you explain how that presents hurdles for the patient very quickly?
Well, I mean, I don't know, Steffie, do you
I mean, I'm living in New York City. Try to find a primary care doctor in New York City. Once you get one, you stay. You know, it's ridiculous to say find another doctor, and the other doctors can be in a ACO REACH as well. So pretty soon it's going to be, if this goes forward, it's going to be impossible to not be in managed care and not have some sort of corporate entity making profits off of your healthcare for being, as Anna said, a middleman. So this is just an effort to hand over the Medicare program, which is a lot of taxpayer dollars. Just hand it over to corporations for profit making.
Oh, absolutely.
Fantastic. I want to thank you all.
Sorry.
No, go ahead. Go ahead and finish your thought.
No, it's the stated goal of the CMMI and the CMS is to have every single Medicare beneficiary and most Medicaid beneficiaries in an accountable care relationship by 2030. So that's their goal.
Absolutely. Well, thank you all so much for taking the time to be here. What a wonderful panel. I want to encourage everybody to take a look at the ticker down below if you're interested in helping out any of the organizations. We've had the Patreons running there. Once again, just want to shout out March for Medicare for All, Physicians for a National Health Program, Real Progressives, Yellow Vest Actions, and Indie Left Media for sponsoring these events.